Well, hello everyone, and a very warm welcome to you all this evening. I'm absolutely thrilled. We're having the third in our series of 6 webinars on this really compelling topic of ethical dilemmas in treating and managing COVID-19. For those of you who don't know me, my name's Anne-Marie Rafferty, and I had the great privilege of being a past president of KCLA. It's my enormous pleasure and privilege to introduce our speakers this evening. I will introduce them separately. They will talk for roughly 20 minutes each, and then we will have a Q&A session at the end. So first up is going to be Dr. Natasha Curran. Natasha has many strings to her medical bow. She is currently Medical Director of the Health Innovation Network, Joint Director of Clinical Strategy at King's Health Partners, a consultant in pain medicine and anaesthetics at University College London Hospitals, and immediate past lead for pain services at the Pain Steering Group and vice chair of that group. She, like our second speaker, Professor Peter Littlejohns, has a very strong connection with the National Institute for Health and Care Excellence, otherwise known as NICE to its friends, working particularly on guidelines. And she's also an expert reviewer for the British Journal of Pain and Perioperative Medicine. Both our speakers have many distinctions, and I think they've engaged with our topic in different ways. From the ethical standpoint, Natasha has been somewhat pitchforked into the ethical eye of the storm that COVID has raised. And Peter has also a significant engagement with COVID, but both of them are going to approach the subject from different ends of the telescope, as you will soon discover. So without any further ado, I think I'd like to hand over to Natasha. Thanks, Natasha.
Thank you very much, Anne-Marie, and good evening to all of you watching and listening to this. It's a real pleasure to be with you virtually to talk about this subject, and I hope that it will stimulate lots of discussion. So I'm going to start sharing my screen, and I can see it, so I hope you can too. Please, if someone can indicate if they can't. So I've entitled this talk, Advocacy, Decision Support and Ethics in a Time of Crisis. And Anne-Marie reflected to me that I could have called it the accidental ethicist, except that I'm nowhere near an ethicist. Nowhere in my job description or skills is ethicist, legal, and as described, and I'll just talk about how I came to be in this situation and what's happened. And I can genuinely tell you that it's been one of the most stimulating and rewarding things that I've done during this period of COVID. And certainly one that did give me a couple of sleepless nights. So I'm going to try and move my screen, but it's not. Oh, yeah, we go. So I'm going to take you back to the context, which in April 2020, it doesn't seem that long ago, but at the same time, it seems years ago. 6 months ago, we were in complete lockdown. Hospitals were starting to fill up, as were our intensive care units. We had massive shortages of PPE, personal protective equipment, for our healthcare workers. And that was causing huge anxiety. At the time, we thought it might be like SARS and that we might be losing lots of our colleagues because they were not protected. And there was also huge anxiety about resource. There was fear all around that we wouldn't have enough ventilators and the number of beds that we needed would be exceeded. We'd seen this in Italy, and we knew also from reports in Italy that some patients weren't able to receive treatment because of resource. So this was something which was very strong. I just want to paint that picture at the time that Peter and I and others started to work on this. And at the same time, another new reality was happening, which was that people in primary care, particularly GPs, were having to assess patients, perhaps whom they've never met before, remotely through a screen to a person in a care home, maybe at the end of a phone, and having to make decisions about what would happen with that person and their care. And so just that is the background, so where we started this work. So one of the immediate things that happened on thinking about the ethics of what might be going on was, well, there's two things. There's two about the patients, but there's also about protecting healthcare workers from the moral injury of having to make decisions when they don't have resource. So the first thing that, one of the first things that London did was to ensure equity across London as a region, which if there's a need for an intensive care bed, for example, an ITU transfer would take place from one hospital to the other. So we were acting as a region in terms of our resource. We were still worried though. And next, I should have put the full name there, the ICS, the Integrated Care Systems, of which there are 5 in London. So we're talking about South East London's here, acted as oversight to ensure that the ethics committees in the hospitals existed in each ICS. And also there was equity of treatment escalation plans, because there's no point if you're going to transfer patients from one hospital to another if they're not treating patients in the same manner and escalating their treatment in the same manner. So that happened in parallel to us also thinking about, well, what about primary care? As I just explained, GPs were having to assess patients in really poor circumstances, getting used to new equipment, personal protective equipment if they were going in, but also virtual means of technology of assessing patients. And so were the public. People were terrified. So we set up 3 layers of support, really. The first was an educational resource, which is still relevant today, and I'm going to show you a snapshot of that. It's quite long. The second was a phone a friend. So if you're a GP potentially by yourself, or potentially going into a situation which you hadn't dealt with before and you weren't sure what to do, or you just wanted just wanted a friendly ear to talk through a situation, you could phone a friend. So we stood up through Consultant Connect, which is a way that GPs can contact, for example, palliative care, care of the elderly, and so on. Another experienced GP who was on call from 8 in the morning till 9 o'clock at night to provide that decision support. And then the last thing was a mental health and community ethics forum. Now, as I said, the acute medical hospitals already had ethics committees, and South London and the Maudsley had set up its own ethics committee, which around COVID, it was in existence, but they wanted to strengthen it. And so we were able to, in South East London, to join the mental health and community aspects of the ethics forum by SLAM hosting that for any cases in the community. And the description of, there was a huge working group that took part in setting up those 3 layers of support. So that involved ethicists, legal experts, psychiatrists, care of the elderly, palliative care, and others, and me chairing that group. And so this is just part of the educational resource, which is still available to people. I can send a link for that if people are interested. And it really the working group really came back to the point was that we need to make sure we're doing good medical practice in the most difficult of circumstances. Patients are vulnerable. Some patients are more vulnerable than others, and we have to advocate. So are we being an advocate first and foremost for this person? Are we starting from a point of providing access rather than denying it for this individual in their individual needs and with their individual preferences? Who have I involved in this decision? Are there any assumptions about resources or preferences that I've made? How can I check? And am I recording this decision comprehensively and appropriately? And so it goes on. There's just one more point that I want to bring out from it, which was the balance in advocacy between equality and avoiding harm. And 2 sort of spheres really of thinking about social vulnerability to discrimination on one side. So thereby our duties of equity and fairness are really important. and we default to in favour of life, with the chance to have a future. And on the other hand, the kind of physical vulnerability to dying badly, what we didn't want was lots of futility, patients thinking that they would potentially, or their families thinking that they would have the best treatment if they were in intensive care, but actually they might actually suffer then from an unmedicalised death, from an unnecessarily medicalised death. And the default being to favouring in the quality of life that a person would want. And also, of course, the long-term sequelae from intensive care, which I still think that I think the public's much more aware, actually, given the media coverage in the last 6 months about what it means to be in intensive care and recovery. But I think in April, people were less aware about that. So about the ethics forum then. So the membership is diverse. It has clinicians, who are GPs, psychiatrists, palliative medicine doctors, nurses, me as an anaesthetist and pain specialist. It has medical legal experts, lay members, and equality leads. And it not only discusses individual cases, but policy for the trust or for the wider community. I can tell you that, as I said, I'm not qualified in any of these things apart from, having some capacity to chair. And there's an awful lot of law and emerging guidance to contend with. And I've just put a selection of some of the stuff down there. And I had to listen really hard to my colleagues to make sense of those, to come to good conclusions for the patients and policies. So I'm just now going to move on to, I'm going to talk about two areas really. One where sort of groupings of cases which came up, and then one individual case. It's really difficult in a short presentation to describe to you the nuances of a case, obviously it's got to be confidential, and also the challenge and the different perspectives which come on from maybe 20 people intelligently and thoughtfully discussing and bringing questions to a clinical team potentially who are bringing a case. So each forum lasts 45 minutes, and that's usually enough for a more simple of the more complicated cases to be discussed, and for some recommendations. We never give decisions because it's not for the ethics forum to give decisions, but to give some advice or recommendations on next steps for a clinical team. Many of the cases that were brought to the ethics forum were around concerns about transmission of COVID to other people. And you can imagine this happened in a myriad of different circumstances. I've just put a few here to sort of whet your appetite, really. So firstly, how do you manage a patient who's got psychosis or an affective disorder, or maybe a cognitive impairment, or all three, who is diagnosed with COVID and is refusing to isolate at his or her care home, and always difficult to manage? So a lot of the instances started off with individual cases like this. Well, what do we do with them? Restraint, medication, you can't imprison people. How do you manage an individual? And then it might go on to then, well, as a policy, what do we do with patients in care homes with dementia and COVID who are wandering around? Should we sedate them? Should we restrain them? How do we protect the other people in the care home? What do our staff do? And so forth and so on. Another example might be, well, what do we do with a patient with COVID who's unable to self-isolate when they come out of an acute hospital or mental health trust with COVID? Or conversely, what about a patient who hasn't got COVID, who's being then discharged into a place which has got COVID? And I'm very happy to discuss some of these things with you afterwards. Not being an expert, she causes distress. And then there was another really strong theme looking at the cases which came particularly at the beginning, which was about the uncertain risk that certain procedures gave to staff. So there are some that were known to be aerosol generating, but others that weren't, like chest compressions, for example. And some of these debates are still going on, and particularly because patients and people may be in different settings. So what do first responders do? What do people who are then going to, for example, intubate a patient do is much clearer. And there were statements like this one from the BMA at the time, that doctors would be supported to not treat a patient if they were in a high-risk situation and had insufficient PPE. There's also an issue that was raised about staff with beards and ill-fitting of masks. So, and what happens if they were told, initial guidance was on had to be clean shaven. Well, how does that interact with a person's belief that their beard is important to them, or that it's important for other reasons, for example, for religious or cultural? And there were other things that came to the ethics forum in this time, such as non-COVID related questions, which frequently come up about advanced decisions, mental capacity, and so on. So I could talk about many different thoughts I had during my time doing the ethics work. I think every case raises new issues. And then, just as I described in the first situation with the patient who might be wandering around whilst they've got COVID, unaware that they might be giving it to other people, it then raises a policy for a wider group, if you like. And the variety of perspectives that were given at the forum really turns a case on its head. It really enables us to think about advocacy. It helps us to do what we think we don't want to do, and brings out unconscious biases without judgment. One that was brought out for me, my own unconscious bias, was around a patient not wanting to have a particular treatment because of their delusion, their delusional belief. And it really made me realise that just because what I think is medically the least risk for a patient may not always be in the right context. The space given for the clinical team really helps them to reflect and move on, even if we don't give them any answers. And having been thrown into this, I realised that a crisis can open our eyes to an unmet need. We now have community ethics support, which I suspect will continue in South East London until it's deemed no longer useful. And people can rally to create something new. I never expected that I'd be doing this, and I'm incredibly grateful to all the people that helped to make it possible. So that's all I wanted to say in a talk, but I'm really delighted to be talking with you about it after Peter's talk. Thank you.
Thanks very much, Natasha. That's, I think, a sprint speed experience that you had, highly concentrated and very intense implosion, as a psychologist would say, into COVID, and how it dramatically brings to the fore all of these different ethical dilemmas. And to continue our theme, but with a slightly different technical approach, because I know that Peter's mentioned that his connection isn't quite as strong as he would like. So Peter will probably move off screen once we start showing his slides. But it's a huge pleasure and privilege to introduce Professor Peter Littlejohns, who I'm sure is also known to many of you, who is Emeritus Professor of Public Health at the Centre for Implementation Science at King's, and also Deputy Director of the National Institute of Health Research, Applied Research Collaboration in South London, and lead for its public health and multimorbidity theme. He's been a pioneer, and that's probably where many of us know Peter from, really a great founder of the work of the National Institute for Clinical Excellence, and was its first clinical director, where he really innovated in bringing the patient voice and public involvement into the decision-making processes of NICE itself. And I think many lessons have been learned from that trailblazing work that Peter and colleagues actually did. And he was there for 13 years until we managed to pinch him from NICE and recruit him to King's, where he established an international research program within the Department of Public Health. And again, this interest in values really comes to the fore, and how values underpin clinical decision-making, and particularly, and this is relevant to his work in NICE, resource allocation. And that theme we'll see is threaded through his presentation. He's a clinician of great distinction, and I think one of his standout features is having been, this also seems like a really fun thing to do, having been invited to the Rockefeller Foundation in 2018 for an academic residency. Maybe he'll tell us a little bit about that at some point. But I think it's also noteworthy in the alumni context that he was awarded a King's Award for most significant contribution to staff experience and engagement. Maybe you might share your secrets with us offline on that as well, Peter. But without any further ado, I'll just hand over to Peter to talk to us this evening about the ethics of COVID, a journey to where? ? Peter.
Anne-Marie, thank you very much for that very warm welcome, and also thanks the organisation for inviting me. It must be a record to have a whole session on ethics without having an ethicist doing the presentation. I'm a doctor of 40 years working in the NHS, 30 years with public health as my main specialty. And I've become very interested in the issue of fairness in the National Health Service, particularly in times of when there's limited resource. And of course, COVID is a classic example of that. And that's what I'll be talking about. As you know, COVID is changing day by day. And indeed, my talk has changed from the title that Anne-Marie gave you. So I will now hand over to Barry, my assistant, to put up my talk. And I will mute, I won't mute myself, but I will switch the video off because technically speaking, I suffer from narrow bandwidth, and I tend to go rather fuzzy if I don't do that. So I'll switch the video off. So my title is The Ethics of COVID, Not Too Late to Prioritize Justice. And it's a very different perspective from the one Natasha took, but is equally challenging, and I'm sure will trigger the necessary discussions that we'll have when I finish. Can I have the next slide, please, Barry? So it's a bioethical seminar, so we need to get to grips with the details. And there's a few slides that emphasize what the key, historically and traditionally, what the key principles have been. And these are not new to any of you, I'm sure. The key to start with is that social contract between the patient and the practitioner that allows informed consent to allow that practitioner to then intervene, hopefully to the benefit of the patient and to avoid doing harm. But this concept of non-maleficence raises issue of commission and omission, which is particularly relevant to the COVID discussion. The fourth generalized principle of bioethics is often missed, and that's justice. It's called justice, but we would really consider it as being fairness, and so that patients with same conditions can expect equal treatment. So these four principles, values, some consider them being equal, others consider there's a hierarchy, but as easy as it might be to consider them as a whole, there's often differences between them. For example, you can provide benefit to a patient with a drug, but that drug will have side effects that will cause problems. So it's a balance. As a public health doctor, I see that actually the priority is around justice and fairness, and that is the framework within which all these other challenges of bioethics can be discussed. And next slide, please. So my proposition tonight is that to achieve justice in healthcare, prioritization is inevitable, and it can be based on ethical criteria and fair processes, or be haphazard and unfair. And to prioritize fairly, you need to articulate values or principles and develop fair processes. And I'll argue that COVID has highlighted all these issues within the last few months. Next slide, please. Just a few detailed bioethical concepts. The first is two general approaches to how you assess fairness. The first, what an ethicist would call consequentialist maximization, and which I would call a public health perspective. It's one where you look at maximizing the benefit across society. Originally, Jeremy Bentham from UCL talked about utilitarianism, and this is the view that NICE has taken over its time, using cost effectiveness analysis and using cost per quality, so-called quality, and which is very important in the context of the NHS, where you have limited resources and you can only spend one healthcare pound once. If you spend it ineffectively, then somebody else will suffer. The second is akin to the clinical bioethical model, where the strength of the argument is around the individual claim. And these two approaches have been debated for decades. And while each of them taken to the extreme can lead to unfairness, in general, that debate continues without any obvious answers. And most of us are on a spectrum between the totally public health perspective and the individual priority for individual patients. Next slide, please. So complicated is this that some bioethicists, and this is Norman Daniels, professor of population ethics from Harvard, says that you can't come to any conclusion on prioritization. Like-minded people, given the same evidence, given the same principles, will come out with different answers. So his argument is that you need procedural justice, and he coined the phrase accountability for reasonableness. And his argument is that to get a priority system in place, you need to be transparent, make public the circumstances and the criteria that you're going to use to ensure that those are relevant to the key players, and that is within a process of challenge, revision, and regulation. And I'll be coming back to this framework when I talk about the response of the British government to COVID. Next slide, please. The other issue from a population perspective that is so key to COVID is the relationship between the state, the government, and public health. A few years ago, the Nuffield Council for Bioethics undertook a review of that relationship and produced a document that they advertised the view that the government is a steward of public health, and that there is a hierarchical ladder that the government can introduce to ensure that public health is maximized. And you can start with the government enabling choice about behaviors. An example here is you initiate stop smoking programs, right through to eliminating choice, introducing laws that limit individuals' rights and responsibilities. And of course, over the last few months, we've just gone shooting up the ladder to a very legally binding system of public health. Next slide, please. So where has prioritization happened in COVID? Well, I'll just take you through some of the examples chronologically. The first is that at a national level, COVID patients were prioritized over all other routine patients. This was a diktat from government, and in the context of NHS England, no white papers, no dialogue, no consultation. All patients, routine patients, would be not allowed into hospital. Routine lists were closed. And in practice, the NHS became a COVID institution. The next period happened when the crisis, the COVID pandemic started peaking, that there was a whole series of limitations of resources. There was a lack of access to intensive care units, ventilators, PPE, test and trace. The prioritization here was still explicit, but it was mainly at regional and national level. The government didn't produce national ethical frameworks. They relied on specialty organizations and local organizations to do that. And we've heard how South London, through Natasha, set their programs up. There have been some national frameworks. BMA produced one. NICE has produced some national guidance, but it's mainly around a clinical area rather than ethical support. And indeed, the first guidance that NICE developed had to be withdrawn within a week because it was deemed to be discriminatory against people with disability. The next big prioritization was not explicit, it was implicit, and hospital patients were prioritized over social care patients. It was the height of the epidemic and the beds were short in hospital and patients were transferred very quickly, often without COVID being assessed, back to social care. And that is was the start of the pandemic occurring in social care. And I think historically, when we look back, that would be one of the big mistakes that was made. We then moved into lockdown, and now we're into the realms of unlocking decisions. And this is the first time really that the government is beginning to talk about not just saving lives, but balancing lives versus livelihood. And guidance is no longer existing. It has now become law. And as we've heard this afternoon, Manchester, even though it doesn't want to go into the third tier, will have to do so, and people will have to follow the legal directions. Next slide, please. So what was this strategy that the government introduced to rebuild the UK from after COVID? This was published in July, and if you apply Norman Daniels' accountability for reasonableness framework, it certainly started to provide the public view of what the priorities were and what the criteria for they would use to rebuild. And they talked about being informed by science, fairness, proportionality, privacy, and transparency. Next slide, please. And underlying aim was to save lives, and that was the overriding priority of the government. But they also introduced this concept of livelihood and people's well-being, livelihoods, mental health, and the wider health generally in the context of the impact of the socioeconomic fallout of the closing of our normal civilization. Next slide, please. The question I'm going to raise and spend the next 10 minutes talking about is whose lives? Next slide. Many of us have listened to Chris Whitty when he presented his views of the COVID crisis during the PM's press conferences, and his full review is one of his Gresham lectures. He's now done two, and I would strongly recommend you to listen to them. Provides a much bigger detail of the thinking than the very short prime ministerial press conferences. But he's always identified 4 groups of patients that can die from COVID. The first, the obvious, the direct, COVID is a nasty disease, and assuming that the health service is functioning optimally, patients will still die. But there are 3 sorts of indirect. There are the indirect because the health service may become overwhelmed, and this won't only be COVID, it'll be other patients suffering with emergency conditions. That was the main driver to bring around the lockdown to prevent that happening. But there are also a third section of indirect patients where likely to be affected by the services that have been cancelled. And already there are papers being published on a number of cancer patients we're likely to see because of the termination of the screening services. And also the number of excess numbers of heart attacks and strokes that occurred because patients were too scared or didn't want to go into the health service. And then finally, there is this group of patients, the public, who are going to be have mental illness, physical illness, and increased mortality because of the impact of the socio-economic hardship, not of COVID, but of the attempts to minimize the effects of COVID on the rest of the health system. Next slide, please. Now, the question is, have we been prioritizing the wrong group of people? This is a group of bioethicists from Harvard and other American systems that looked at the public health policy approaches in America, but also relevant to the UK. And they've argued that there are 4 inherent biases in these policies that lead to a tendency to minimize the overall impact, the public health impact of the policies. The first is what health economists would call the identifiable lives bias. It's much easier to concentrate on named patients, grouped patients, and obviously in this context, those with severe COVID are the group that's involved. There is an optimism bias where in practice, humans tend to take the optimistic view. So at the early days, an example in COVID would be the drive for the new ventilators, the drive for new drugs, the vaccine that was going to save us. The third bias is the present. All of us would prefer immediate gratification, even though the benefits would be much greater in the future. And there's also this omission bias, which I think is particularly important, where we would all prefer that a harm occurred by failure to take action, rather than as a direct consequence of the actions that are taken. And a good public health example of this is why people won't get vaccinated. Next slide, please. So was it just these bioethicists in Harvard that was concerned that we were prioritizing the wrong group, that we were actually minimizing the overall socioeconomic effects on health and well-being of our society? Well, increasingly they're not. There's a rather strange alliance of voices coming through that are raising this same debate. And I was listening to Evan Davis last week, 11th of October, when Charles Walker, the vice chairman of the 1922s committee, no bioethicist at all. These are some of his quotes. The fact is, people in their 80s and 90s die. We just can't save every life. You cannot abolish death. This is an illness that very sadly really afflicts the elderly and those with an underlying health condition. Our focus should be on protecting them, not limiting the life chances of young people. The economic impact of strict lockdown rules risks bankrupting the economy and pushing younger people into unemployment. First world public services do require a first world economy. So here is somebody who's not a public health physician, not a bioethicist, but arguing that actually the impact, the socioeconomic effects may well be more and more challenging than the immediate effects of COVID. Next slide, please. But it's not just politicians and bioethicists. A number of epidemiologists, scientists, and doctors are beginning to raise this issue. And I've just used 2 examples. This is the Great Barrington Declaration that emanated from the States. Already has 50,000 members of the public, 6,000 scientists signed up, some of which are from the United Kingdom. But more recently and relevant to us, a whole series of GPs have written to Matt Hancock saying that unless we start addressing the non-COVID related morbidities and mortalities, we're just building up very severe problems for the future. Next slide, please. So where are we now with COVID-19 in the context of the bioethical theories? Well, we no longer have political consensus. Labour now advocating national lockdown and local tracing. government action differs from sage advice. And I just wonder whether we should be worried or relieved that that's happened. And I'm sure that will come up in conversation later. We certainly have national versus local tensions, which have been manifested today. What is also interesting, though, is that there have been different approaches to lockdown in Europe over the summer. But regardless of the success in the beginning, most countries now are locking down and even increasing the severity of the lockdown. And France is just introduced a curfew. What is also interesting is that compliance is beginning to be criticized. A number of narratives coming out of Germany and the USA are talking about blaming the people rather than the policies. So the question is, what do the people think about these issues? And I'm just going to show just 2 more slides. The next slide. NHS England was very concerned about the changes that were taking place in the NHS and what the people thought. And they commissioned Imperial College Health Partners and Ipsos Mori to do a deliberative interaction with the members of the general public to address what they saw as the difficult issues around the NHS and how it could be carried forward. This is not the general issues around lockdown, this is just now around the NHS. Next slide, please. It's a very good report, I would recommend it to you, but just highlighting here the issues around prioritization. This is not around acute prioritization, but prioritizing people coming back into the health service from routine care. And they very strongly advocate clinical severity as the key criteria, which is supported by most bioethical theories. But they're also very wary of other issues, quality of life, impact on ability to work, caring responsibilities. So I think there's a bit of a hint here that the broader approach to addressing how we respond to COVID is required. And I suspect we should repeat this type of study looking at the issues of lockdown and unlock rather than the pure NHS issues. Next slide, please. So where next? Well, I would argue that I'm optimistic about science in the sense that we all hope that a vaccine will come along soon. But the role of science in determining the benefits and disbenefits of lockdown, I think, have probably been exhausted. So can ethics help? Well, I would argue, and I have argued, that it can help, but we need to be brave and move from a clinical bioethical model to a public health model. Or what we could do is just leave it up to the politicians. I will finish there. Thank you very much. Next slide. Thank you for listening.
Thank you very much, Peter. And I think that complements, I think, Natasha's presentation perfectly, giving 2 different but synergistic portraits of the ethical dilemmas and really serious, live and dramatic questions that it raises for politicians, public health, and all manner of clinical practitioners, as well as the public, of course. And it is now to the public that we turn, and our esteemed audience, to ask some questions. So without any further ado, I think we'll just move straight into that part of the evening. So we have a question here from a Dr. A. Addy asking about strokes in younger COVID patients. And the question is the increased risk of strokes in younger COVID patients related to infection-induced atrial fibrillation? So there's a clinical brain teaser. I don't know who wants to take that.
Perhaps I will. I think it's not related to atrial fibrillation, but to a procoagulant tendency. And that's, I think that answers your second question as well. It's that we don't actually know about things it's a new disease, if you like, so we're not sure how to treat these things longer term. But colleagues are assessing how long people should anticoagulate patients for once they go home at the moment.
Thanks, Natasha. I mean, Dr. Addy asks a second question, which is linked to this, which in COVID-19 survivors who are immobile at home, is there a long-term need for some form of thromboprophylaxis, and when should blood coagulation be checked? So
yes, yeah, that's what I meant. It's not known yet, but we're, people are looking at that.
Yeah, exactly. Thanks. Maybe this is one for Peter here, from Brian Sutton. Another aspect of prioritisation is that debate around herd immunity in the long term versus saving lives in the short term. So the balance and trade-offs perhaps between the two. The former policy might militate against the former. Does that make sense? How has this been viewed ethically, and how might that view be able to inform and influence such decisions? Now, I'm trying to pull down the rest of the question. This isn't far from your unlock point, but as I've been modelling, this is on a private and personal basis and following closely, and I've been in touch with government advisors and other such modelers who are clearly aware of such trade-offs. Some countries are doing this better than the UK, in brackets, not that I'm necessarily a fan of the Swedish approach, but that is one country at least that's had a very different approach, in brackets, allegedly. Well, that's quite a long question, and probably
right.
I should.
I'll start off, but I'm sure Natasha can come in. I'm glad it's not a clinical question. I think we probably overdid the fact that we weren't bioethicists. I don't know if you remember, but there was a huge debate at the beginning. It seems ages ago now, but it's only at the beginning. Yeah, so it was February, March, where Patrick Vallance, the chief scientific advisor, hinted that herd immunity was something that we were aiming for, and that we would likely that having we wouldn't try and eradicate the disease, we just have it bubbling away and immunity would build up. Your question is, what's the ethics of that? Well, certainly a lot of my colleagues who are bioethicists were absolutely furious that was seen as or was considered as a national policy. And indeed, very quickly, Patrick Vallance said, well, I was taken out of context. He wasn't talking about that as being a policy. And I am aware that there's been a very active debate on that with, I think, Freedom of Information, looking at the emails exchanges between him and Chris Whitty about this issue. So I think it's true to say that from a public health epidemiological perspective, then herd immunity is something that is advantageous, but it wasn't policy to wait till that happened. The difficulty is, and I'm no expert in COVID pathology, but my understanding is that we're not guaranteed immunity. We're not sure that even the people are beginning to get COVID twice, and the second time people are getting it more severe. So herd immunity is out. The other issue you talk about is the different approaches, and Sweden is obviously a classic example because they did take a very public health perspective. They didn't do the lockdowns, and they did it all very explicitly that this is what they wanted to do, all coming from one single epidemiologist who is their chief epidemiologist. And what has happened, and in fact, I just looked it up today to check on how Sweden was progressing. It certainly has got a higher mortality rate, acute mortality rate due to COVID than others. And they but they haven't had the lockdown to the extent that we had. And they